Good morning, everybody. Day 2 promises to be just as great as day 1, I'm sure. And I have the pleasure of introducing a colleague of mine, Dr. Kerrington Smith, who is an associate professor of surgery at Dartmouth. And again, as we talked about yesterday, one of the best friends as a gastroenterologist you're going to have is your pancreatic surgeon. So I'm honored to have Dr. Smith, who's not only a great colleague, but also a great friend. Kerry.
Thanks, Tim. It's really nice to be here. It's been, I think, maybe 4 years since I was invited to this talk. It's really nice to be here in someplace really warm. I'm going to try to take you guys through what sort of an oxymoron, maybe innovations in pancreas surgery, and where we were and what we're trying to do and where we think we might be going. Yeah, sorry. Yeah, it's a learning curve. This is about the learning curve too, this talk. All right, so what are we, what's the difference between innovation and improvement, right? I mean, we're always trying to improve, trying to make things better. Pancreas surgery definitely there's room for improvement. But what is the true innovation? It's like a paradigm shift, right? It's something that you're not just trying to take something that you do a little bit of and make it better. You're trying to actually completely change what you're actually doing. And then the question is, have we done any of that in pancreatic surgery? So let's talk about sort of what outcomes we're trying to improve. So the first thing, this is a slide taken from a talk where they look at, this is Memorial Sloan Kettering. You're looking at 30-day mortality. The blue is in the 80s, the yellow is the 90s, and then the green is in the 2000s. Not bad, right? At Memorial Sloan Kettering, they're doing pretty good. This is percent sort of survival on the y-axis there. 90-day mortality, of course, some people don't make it past 30 days and it goes up. And then you look at the 1-year mortality, but look at this is like, what are we, 45% in the 80s? And then, you could say this is really success, right? Is this improvement? I guess it is improvement. There, at 1 year, people are living, this is pancreatic cancer, 25%, which is actually not bad. And then you look at the length of stay in the hospital, it went down, as you'd sort of expect, with just sort of making improvements, basically. So this is a classic surgeon comment, like a chance to cut is a chance to cure. Well, let's look at the percent survival on the y-axis here. Same paper, 80s, 90s, 2000s, pancreatic cancer. You're looking, basically these curves are right on top of each other. So I would argue that, they definitely got better at doing surgery, right? They're better surgeons, better techniques, but over the decades, really not a lot of improvement. Certainly no innovation. No offense to, I'm not trying to rag on Memorial Sloan Kettering either, by the way, even though I went to MD Anderson. But, well, no, our data looks the same as theirs, basically. So how can we make it better? Do we get better training, right? All you guys are trainees, right? You're trying to learn how to do something. You learn from your mistakes. That's probably, what do you tell your kids if you guys have kids? Learning from your mistakes, that's the best way to learn, right? As long as you're not the patient where you're learning on, causing the mistake. And then this is true, practice makes perfect. And then the other thing I want to talk about toward the end of the talk is like the technology. Can we make things less invasive? Can we have better oncologic outcomes with just improving technology, improving training, and improving technology? So let's talk about you guys may know the volume relationship between, this is a big, maybe 5-10 years ago, a buzzword in surgery. Better, higher surgical volumes, better or improved mortalities. This is operative mortality on the y-axis here. And it's kind of hard to see, but basically the dark blue is less than 2 cases, okay, across different surgeries, lung resection, cystectomy, esophagectomy, pancreatectomy. And then, looking over here, greater than 17 in the white. Or for Whipple's, for example, greater than 4 surgeries. And it goes down, basically. And you can see, and that's not too surprising. So low surgeons volume, bad mortality, or higher mortality. High surgeon volume, low mortality. But let's kind of just take a second to look at this though, you guys. Y-axis mortality, lung resection, cystectomy, esophagectomy, pancreatectomy. Why are esophagectomies and pancreatectomies, so why do you have a curve basically? Why do you have decreasing mortality with increasing volume? Whereas in cystectomy and lung resection, not really. Maybe the thoracic surgeons are just all really good. They can just do 2 a year and they're amazing. They can do 20 a year and they're amazing. But the reality is, I think what this kind of points to is that these operations are different from these operations, assuming the surgeons are all, trying to do a good job. And, when you look at on this is also another curve looking at surgeon volume and hospital volume. And it's hard to see, but basically all these different like cardiovascular procedures, not a lot of increase based on surgeon volume. Cancer resections, not so much. Esophagectomy, 2.5-fold. But look at pancreatectomies, 3.6, fold increase in operative deaths if you're a low volume surgeon. or a low volume hospital, even over here. So there's something about the Whipple operation or pancreatectomy, something about, I guess, throw in esophagectomies that makes this volume relationship really pretty substantial or pretty remarkable. So I'm going to take you guys through, this is kind of an interesting paper. So the irony behind this is, Burke Meyer, who was at Dartmouth, he was all about volume, right? He published this paper in the late 90s, New England Journal, about surgeon volume. But then let's talk about skill. So this is a low-rated surgeon. They took basically 20 surgeons from Michigan who are bariatric surgeons. I don't know how these guys signed up for this, but then they submitted videos of their cases. No, really. And then there was a panel, I think, of 10 surgeons who then watched these cases blinded, right? They didn't know who might have been their own case, I guess. And then they just started rating them. So you have the surgeon on the left, and I don't know if you guys can, this is probably not the greatest thing to watch right before while you're eating your breakfast, but I mean, they're just trying to do a side-to-side jejunojejunostomy and anastomosis. This surgeon's kind of pulling on the tissue here. I don't know, it's kind of hard to see back to back. And whereas this high-rated surgeon, it's very, you get much more room in the field. These ports are right on top. This guy's trying to sew this thing and see the tension and pulling. And then whereas this surgeon makes, they obviously chose the, one end of the spectrum and the other end of the spectrum, and there's obviously people in the middle. But what this pointed to was that, basically cut well, sew well, get well. If you have good skill, you also, and volume and skill, you're probably gonna have good outcomes. So if you look at their outcomes then, this is that same paper. They're looking at reoperation. The blue is the sort of the low quality surgeon, and the yellow is the high quality surgeon. Readmission rate was improved, emergency room visits, and this is for Roux-en-Y gastric bypass, bariatric surgery. So and I guess this is, when this came out, everyone was like, oh, duh, yeah, there's good surgeons and bad surgeons, right? But the reality is this was the first kind of time that they tried to quantify it and correlate it with outcomes. Technical problem here again, sorry. All right, so this is interesting. You guys will like this, I guess, because this is general surgery trainees. All right, so how do surgeons acquire skill? How do they get volumes? This is the 2019, Tim, I don't know if as a program director you have this for GI, but we have for the ACGME, these are the procedures to graduate as a chief resident you have to do. I don't know if you can't really see it here, but basically 850 major cases, 200 chief year cases, that's where you're the primary first assist. And then look at this, 5 pancreas cases. So how do you graduate from a general surgery program, and then you have to be then you say, oh, I can do this. You don't have to do a fellowship, honestly. And then you have to become a high volume surgeon, having only done 5. I was at the University of Chicago. I did 7 during my residency training. And you can't really get good at doing something or watching someone else do something having done it only 7 times. So let's talk about the learning curve. This has been studied. This is open Whipple, for example, MD Anderson. And how do you define, what's a good learning curve or a good outcome? All right, decreased EBL or estimated blood loss, decreased operative time. That's a surrogate for a surgeon efficiency. Length of stay, of course, and then you want to have good oncologic outcomes, so negative margins. It took them 60 cases. These are attendings. When they looked back, 60 cases for the attendings to be altering these parameters. So it's basically like a 50, 60 case learning curve for open Whipple. So you go from 4 in your residency, and you have to get to 60 in order to be and that's for open surgery, okay? We're gonna shift gears instead of the volume thing here. Let me go back. So we talked about better training. Okay, what about better technology? Can we do it less invasive and also have better oncologic outcomes? That's where, with training and technology, we might make improvements. This is open surgery, okay? We know this is sort of a field. This is, I think, one of my cases where we've dissected everything out. This is kind of what the patient looks like with a G-tube here, large incision. There's more, no matter what study you look at, basically more blood loss, definitely more postoperative pain, more complications in a general sense, although that's debatable. Definitely longer in the hospital. Longer, time, if they measure how long does it take to get the patient back to work, takes longer. Okay, delayed time to adjuvant therapy. And there's some data coming out that if we could do this better, the patients would get to adjuvant therapy quicker. Okay, and more patients would too. And then this is the minimally invasive surgery or MIS surgery, less pain, less blood loss, less complications, less time in the hospital, quicker recovery, and get the patient to adjuvant therapy. If we could do this, take a patient where we're doing it minimally invasively for some reason with tiny incisions, can we have improved outcomes? Okay. this is, I don't know, we can't do anything or agree that anything's a real change unless we do a randomized controlled trial. 1990s, cholecystectomy, we had to do a randomized controlled trial, 1998. Then the colectomy in the 2000s. This is 2015. They're trying to decide, should we do a randomized controlled trial, randomizing patients to open to laparoscopic distal pancreatectomy, and discussing it. Can it be done? Is it something that we need to do? And it just goes to show you how, even in this day and age with pancreas surgery, we're still, with MIS pancreas surgery, minimally invasive, we're still not quite there yet. We can't even we're just talking about the trial, I guess. In Europe, they'll do it. I think the Dutch just did it, actually, in the laparoscopic case. I know you guys know all about probably the Whipple surgery, but I want to take you through this a little bit because I want to talk about the Achilles heel of this operation. We have to divide the bile duct, whether you do an antrectomy or a pylorus preserving the proximal jejunum here. You have to divide all these structures. And then for the reconstruction, this is the problem, the pancreaticojejunostomy. And this is truly the Achilles heel, because we can basically do this safely, minimally invasively, open, however you want to say it. Same thing with the gastrojejunostomy. But the pancreaticojejunostomy, no matter how you do it, has always been fraught with problems. So when you look at the minimally invasive versus open Whipple sort of data, the con is that it just takes longer for minimally invasive operations. Now, is that because you're in this learning curve? The surgeon did 60 open, and then they have to do 60 laparoscopic or minimally invasive? Or is it, and then the pro would be you have less blood loss, shorter hospital stays, take more lymph nodes, supposedly in some studies. And we don't know, what about the complications, recurrence rates, survival, of course. Can they get to adjuvant therapy? And then, of course, cost. Those are kind of still the unknowns, depending upon how you want to look at minimally invasive surgery. There are really two different platforms, laparoscopic platform and robotic platform. Both have small incisions. Laparoscopic, you're looking at a TV screen, so you're in 2D. Even though you have high definition HD TV, you're still 2D. Whereas robotic, you're 3D. It's as if you're doing it, on the patient, so to speak. But the good thing about laparoscopic surgery, you have haptic feedback. You can pick up a tissue and feel it, right? Robotically, you're gripping things, you have no feel at all, and you just space out for a second and pull, you're ripping that tissue. So you have no haptic feedback, and they're working on trying to get that, and you also have limited range of motion. You're going in, we use, I don't know if surgeons in the room, they know it's called straight stick, where you're coming in with these laparoscopic instruments with basically little tweezers and twisting them and turning them, but you don't have a wrist like you would if you were doing it robotically, and then the ergonomics are poor. Try doing a Whipple laparoscopic, whereas when you're doing it robotic, you're literally sitting down. So the surgeon longevity, surgeons love to talk about that because we want to be able to, not have back problems and other problems. This is the data that I could find on this laparoscopic Whipple series. Michael Kendrick had, let's just look at this OR time, conversion rate, EBL, length of stay, morbidity, mortality, and then there's a couple robotic Whipple series. This is University of Pittsburgh. Okay, and if you look here, they're basically kind of the same. Let me go back, sorry. You can't really, you look at OR time, it's about the same, percent conversion about the same, EBL, really about the same. And we're just comparing these, this is not real true science, we're just comparing these series. But the question is, should we be doing it laparoscopic or should we be doing it Whipple? And the reality is, if you can do it laparoscopically or you can do it robotically, you're probably doing it the same as the other person who can do it well. That's what this shows. This is a video of basically the pancreaticojejunostomy open. And you can just kind of see, I don't know, you guys can't really see this, but surgeon's hand is, this is not me, surgeon's hand is shaking. There's the field, he's got a huge duct to sew to, he or she, sorry, it could be a woman surgeon doing this operation, but see, it's not very precise. And if you take we know what the problem with the pancreaticojejunostomy is it's basically the leak rate, right? Anywhere from 10 to 45% in series you look at, are the pancreas or Whipple cases will have a pancreatic leak. And we know it's a firm patient, pancreas, large duct like this patient, low leak rate. Soft gland, small duct, high leak rate. So that's basically, and we know we can stratify the patients accordingly. And if you go on, let me get out of this video here. And the other thing, when you look at the Whipple operation and the pancreaticojejunostomy, there must be a problem, right? Because if there was one way to do it that was the best way to do it, we would just all be doing it the same way, and we don't. There's many different ways to reconstruct the intestine, bringing it retromesenteric, retrocolic, anticolic. Should we make a Roux-en-Y? Every case can be potentially different. The duct to mucosa anastomosis, where you're sewing the duct to this tiny little hole in the intestine, to do an invaginating anastomosis. Should we use a stent? Should we not use a stent? I mean, there's a randomized study saying, should we use a drain and not use a drain? And that took years to accomplish, just to try to understand those basic questions. So when we talked about surgical skill and technique matters, this is an interesting paper that came out. And what they did was, guys, when we do the open Whipple surgery, we have the loops, thanks. 2.5x magnification versus the microscope, and they had randomized people that had getting microscope assisted pancreatic ojegonostomy, 12.5 times magnification. But if you look at a small duct, there really wasn't a big difference. So basically, anybody with a small duct, you can sew that together, where you don't need a microscope. But with a large duct. With a small duct, though, they went from a 21% leak rate down to 11, just with the microscope. So what does that tell you? I mean, maybe there's something about the technique, something about the skill of the surgeon that needs to be altered. So now we're getting into the technology. Well, if a microscope is good, what about a robot? Would a robot be better doing or helping the surgeon? This video went viral, I don't know how many years ago. Like basically this robot sewing his grape. But you can see that you have improved dexterity. There's a wrist. This is like a really slow robot surgeon sewing a grape. And there's better visualization. I'm going to move out of the grape for a second for the sake of time. So the question is this better though? This is the pancreatic, this is from Pittsburgh. I stole this from them. They're doing the pancreatic ojegonostomy. I don't know if this is, anyway, and you can see, I mean, this is also sped up, I think. I don't think they're quite this fast. But you can see, there's a little bleeding, but it's very precise. The field is set. There's a little stent in the duct. That's the cut edge of the pancreas. They're sewing this together. And there are advantages to this robotic platform. I mean, all those little wristed instruments, and there's no tremor. And they're making the pancreatic ojegonostomy here. So let me just go. I only have a few more slides, you guys. I know we're trying to stay on the schedule. All right, so now have you got anybody? I'm going to go back one slide. So is this an improvement? In the old days, this is back when I was training in med school and stuff. You had the handwritten chart. You're writing stuff down. You're writing orders. You're trying to write notes. Now, in the 2000s, I guess we had dictation where you'd talk into the telephone, call up a number, and someone would dictate. And now we have Dragon's not the only company, but we have Dragon Speak. Tim knows this. I started using Dragon when we first, 10 years ago, and I felt like I was at a McDonald's trying to order something because I had to speak in this weird tone of voice. But now I can do anything. I can throw in an accent, Scottish accent, whatever. Now, Dragon doesn't make mistakes. How is that possible? It's all about the volume of cases. Think about the company that owns that data. From every time you speak into Dragon, they own it. And they can tell how you speak, it learns how you speak, and it just makes it better. And so as time goes on, Dragon got a lot better. Okay? What about, this is autonomous vehicles. Is this an improvement or innovation? You have this old 2002 BMW here. Here's a Tesla taking off, supposedly. I've actually this is apparently happening right now. You guys probably all have these. We don't have these up in New Hampshire. But so look at this thing. This is also sped up. No, but this is crazy. This guy's driving this thing. You can see it here. And look at all the variability in the road. There's cars passing. I mean, this car it has sensors. It can sense what's going on, right? But it's just fascinating to think what they're doing right now with autonomous vehicles. And then level 5, fully autonomous vehicles that you won't even have a steering wheel. You'll just get in the car. In fact, you'll park your car at night, and that car will drive itself. You'll loan it out, and they'll be driving packages back and forth. You'll be making money or sleep while the car works for you. Sorry. Now, you know where I'm going with this. 1 second. All right, so here we are. Could we take artificial intelligence, data science, big data, and then whoever owns that data could then theoretically design programs or platforms such that, and I'm not saying that the robot's going to do or the computer is going to do the surgery, but what if the surgeon here is doing a gallbladder? Here's the critical view of safety, cystic duct, cystic artery, bile duct somewhere over here trying to get divided. If this is an easy case, but what if you had a computer-assisted view, and all of a sudden you got some vibration or something popped up and said, whoa, you're getting too close to the thermal injury on the hook cautery is too close to the bile duct, and you're going to have an injury. And that would be like a computer-assisted surgery, and that's coming. It's definitely why, because it's going to be safer. And once they figure out it's safer, the hospitals aren't going to want to have unsafe surgeons, and so they don't want to have bile duct injuries. And whether or not it's actually going to be fully autonomous, this is the last slide here, or a couple slides here. I just wanted to bring up one thing, actually, for people from Hopkins. So, John Cameron, this is like surgery 2.0. Like a surgeon does open surgery 1.0. John Cameron's done 2,000. He published the 2,000 Whipples. And so this is pretty amazing data. Mortality, leak rate, wound infections, pretty low. 5-year mortality, this is pancreas cancer N0, R0, margin negative. That's a pretty good number at Hopkins over whatever, these are decades from one surgeon. But that's one surgeon doing 2,000, okay? Right now, the company I don't have any connection to the company, by the way, but let's just call it robotic or computer assisted. They've done over 6 million. So how much, if you owned that data, or the people, or if you could do data sharing and it was for free, and everyone shared the data, we would be doing a lot better than just one surgeon who's an amazing surgeon doing 2,000. And so artificial intelligence, are we going to be innovating? Is robotics going to be the future? It's basically the jury's still out. I personally don't think it's going to be autonomous surgery, but I definitely think we're going to have computer-assisted surgery. It's just a matter of time, and it might help us be safer and have better outcomes. Thank you.
Questions for Dr. Smith?
Yeah.
Excellent talk. I have 2 questions. I haven't seen any meta-analysis of all the lap Whipple, both robotic as well as manual. Manual, I think, is only Mike Hendrick doing. But my question is, if there is a meta-analysis, which I don't know, but you may be knowing, are you finding more choledochojejunostomy and pancreaticojejunostomy strictures when you do minimally invasive compared to open? The second question is, just like we have NAFLD epidemic, now we have NAFPD epidemic, the fatty pancreas. So we are seeing more and more in the last 15 years every year. Has that impacted your pancreaticojejunostomy anastomosis in any way?
Those are great questions. Yeah, I'll take the first question with the strictures. I'll just tell you right now, when you're doing it, I don't know about the laparoscopic. I don't do lap Whipples. I do robotic Whipples. You're sometimes running that anastomosis, whereas when you're open, you're interrupting it. And so I try to do it exactly the same way as I do it open, so you theoretically wouldn't have these strictures. But I think if you look at a lot of volume of surgeons, they're going to be running that anastomosis. Why? Because it's just technically easier to do it. You mean running, just taking the same stitch, going back and forth, and then when you tighten it, it strictures a little bit. That's a possibility, and I bet you that's what we're going to find. And then with regard to the fatty pancreas, you guys are all studying the fatty pancreas. I just think of it as a soft pancreas, and the soft pancreas is way harder to sew. I tell my patients it's like a stick of butter if you leave it out at night, and just sitting on the counter or whatever, that's what you're putting stitches into. And so the fatty pancreas, yeah, we're going to have, and the leak rates will be higher. And every study has shown that. So I don't know. I do think the computer-assisted robotic surgery, pancreaticojejunostomy, is technically a better anastomosis than I do it. I do it better robotically than I do it open because of the visualization and the degree of freedoms with the wrist, things like that. But yeah, that'll be a problem in the future, I bet, as people are more obese and we have that issue. Great, thank you.
Any more questions? Thank you very much, Dr.